Thanks, everybody. I'm just going to give you a presentation. I'm looking forward to questions. I don't have a PowerPoint, but in the chat, I'm going to put some links in there as we go for some of the content that we're talking about. So just to give you a little bit of background on the American Medical Association and me personally. So I am in private practice. I'm here in Flint, Michigan, my hometown that I grew up in, that my parents immigrated to back in 1970. And I share my office with my wife, Nita, not just this office at home, and that's her desk behind me, but our main medical office, our only medical office, is a place where people come for earwax and they come and see me, or they come for pap smears and they go and see my wife, Nita, on the other side of the office. But that's our day job. But as you heard, I also serve on the board of trustees of the American Medical Association, was chair of that board last year. But a little bit about the American Medical Association. So it's based in Chicago. It's about 175 years old. And what I will say about that age is that it comes with a lot of wisdom and historical context that you already sort of heard referenced a little bit here, but also with a lot of inertia, right? So with 175 years of age and history and policy behind us, it's not the kind of thing that turns quickly. And that's sometimes by intention, and sometimes that's a good thing, and sometimes that's not a good thing. The policy of the AMA is set by our House of Delegates. And so our House of Delegates represents 190 states and specialty organizations. We have about more than 600 voting members, so delegates that represent these states and societies, pretty evenly split between states and specialties. So for example, we have 8 representatives from anesthesia, and another 8 from ACEP, the emergency physicians. We have 13 physicians from Michigan that go. We have 34 physicians from the American College of Physicians. It was referenced for some of their work product in the earlier presentation we just saw. So just an example of sort of how that policy-making body is constituted. The reason I mention it is that later on I'm going to talk about some of that policy that's been created. As far as the other aspects of diversity within that policy-making body, we have medical students that are there. We have senior physicians that are there, and everybody in between. So we have about 27 medical students that vote in our House of Delegates. We have a young physician section. We have an independent practice, private practice physician section. We have an integrated physician section, residents. So basically every stage of the career of a physician is represented in that policy-making body. There's a lot of tendency to think that the AMA is a room full of end-of-career physicians making that policy, but we just came back from that meeting yesterday, and I can tell you that half of our resolutions, which is our items of business, were brought by early career physicians and medical students. And basically, just to elaborate on that, if somebody has an idea, then it comes to the AMA as a resolution through whether it's the medical student section or the young physicians or the American Academy of Otolaryngology. It comes to our House of Delegates, this voting entity of about 600 people that decides, is this going to become the policy of the American Medical Association? So some of the content that I'm going to talk about later was voted upon by this group. And sometimes it's a 90-10 vote, 90% in favor and 10% against, or sometimes it's a 55-45 split. But it's a majority that makes the policy of the AMA in this process. And also the split in this group pretty much is indicative of the various practice environments of our physicians. So in our country right now, we have just under 50% of physicians owning their own practice in private practice, and just over 50% in an employed situation. And both groups are represented pretty much in that same way within our policymaking body. So whether it's hospital consolidation, whether it's health plan consolidation, this is the kind of thing that the AMA has our eye on because people bring this to our attention. So what I will put here, so this first link is, the first link that I put in there is the report of the Council on Medical Service. So the AMA creates its content based on various entities. So we have a Council on Medical Service, we have a Council on Legislation, we have a Council on Science and Public Health. So these are all the different groups that sort of create the work product that then gets presented to our House of Delegates to either get accepted as our policy based on a vote or not. And so what I put in there is a report from the Council on Medical Service on exactly this issue in 2019. So sort of the influence of private equity and the corporate practice of medicine. So this emphasized that the AMA supports a plurality of physician practice models, meaning that we are not endorsing one model versus another. We want there to be multiple options for physicians based on what they're seeking in their practice and what they're seeking from how they want to take care of their patients. And so we want the physicians to have the right to choose this practice model that best suits their needs, and we urge physicians to sort of do the due diligence on each of these models, right? So don't jump in without doing that due diligence, and especially and including related to private equity and engagements. So the AMA House of Delegates has also directed our Council on Ethical and Judicial Affairs that you heard referenced in the last presentation by Sailesh, to further sort of develop ethical guidelines as it relates to these challenges. And I'll reference that. We'll get back to that in a second. So this report from the Council on Medical Service, I'll just kind of highlight some of the things, and again, the link is there. But what that report says in its executive summary is that while that extent of corporate investments is not precisely known but is growing, there are more and more physicians that are employed by corporations, including hospitals and health systems and insurers. So just for example, the largest employed group of physicians in this country is in the Optum medical group that's owned by an insurance company, United Health Group. And we heard that referenced. And so this is not something that's unique to private equity. This is something that exists in multiple aspects. And so Optum, being the largest group of physicians, is owned by United Health. Increasingly, as we know, and we've talked about already today, private equity firms have also acquired a majority and controlling interest in a lot of entities that manage medical practices. So there's risks to this and there's benefits to this. And so in this report, you'll see that the risks include, loss of control over physician practice, all the things that you've been hearing about today, loss of autonomy in decision-making, an emphasis on profit or meeting financial goals, potential conflicts of interest, et cetera. The benefits, which you might not have heard a lot about today, but include sort of financial benefits to physicians looking to exit ownership of their practices, right? So being able to take something that they've worked their entire career to build and have it have value, as opposed to closing the doors or trying to sell it to a practice or to a hospital system. Access to capital for practice expenses or expansions. That's not something that's easy to come by. And that will also, again, relieve physicians' financial pressures. The average medical student graduates from medical school nowadays with $250,000 in loans, right? And so this is an avenue to be able to grow a practice, to buy the things that are necessary for a practice and pay back those loans. Potentially fewer administrative and regulatory burdens that can be sort of offloaded into this other entity, right? So the fact that a given physician in practice may not want to have to deal with things like prior authorization, right? And an outside entity, whether that's private equity, whether that's a hospital employer, will have an entire department that works on things like prior authorizations. There's a statistic about prior authorization that's shocking. For every physician in this country, there is 1.4 employees just working on prior authorization. That is a practice expense that can be offloaded to a non-clinical entity to help with that. So again, these are some of the benefits of aligning with an investor like a private equity company or a hospital system. But concerns regarding these partnerships have been primarily centered on the potential for subsequent increase in prices, service volume, internal referrals, just unsupervised non-physician care. These are all sort of the downsides that we've already heard about. But again, it's longstanding AMA policy that physicians are free to choose the mode of their practice and enter into contractual arrangements as they see fit. So again, there's guidelines in this report to sort of point out what to look for in these arrangements. And so the AMA basically says that physicians who are contemplating these investor partnerships consider these guidelines, that we should consider the practice's mission and vision and long-term alignment, and long-term goals, and whether that aligns with the corporate investor. It shouldn't be assumed that those two things are aligned. There's due diligence that needs to be considered, obviously. So at a minimum, reviewing the corporate investor model, the strategic plan, the leadership, the governance of that entity, right? We shouldn't loop all of these outside investors into one homogenous group when they're very likely not homogenous in their vision and whether they're hands-off or hands-on. The physician should consider whether or not their corporate investor and that partnership will require physicians to cede varying degrees of control over practice decision-making, right? So those entities that sort of want all of that control, that's something to stay away from. Those entities that are truly sort of providing capital and are not hands-on as far as management are something that a physician would consider. That the physician should also consider the potential impact of this corporate investor partnership on employee satisfaction and future physician recruitment. So again, the details, there's more recommendations than that, but basically the physician should retain responsibility for the clinical governance, the patient welfare, patient outcomes, physician clinical autonomy, physician due process in these corporate partnerships. That should not be ceded to the corporate partner. And then each individual physician should again have that ultimate decision-making ability for medical judgment. So a couple other things that I'll highlight. Let me see if I can copy this also. I'm sorry, I know there's a lot going in the chat, but I can't speak to you and answer those questions, but I'll try to get to those in the Q&A. So we have within the AMA a physician satisfaction and practice sustainability work group, a section of our AMA. And so we worked on, or that entity worked on with an external legal firm to create the venture capital and private equity investment, how to evaluate contractual arrangements. And so you'll see that in the link there. But in that conclusion, the conclusion of that report in 2019 was that VC or private equity backed investments could present an opportunity for physicians looking to either grow or sell their existing practice. So with an informed evaluation and negotiation of terms, this kind of investment could provide new resources to fund clinical and technological improvements and provide financial stability. However, physicians should understand the terms of that investment, right? So not assume or not jump to that conclusion or to that salvation, so to speak, without doing this due diligence, and make sure that those, that the terms of that investment are aligned with the goals of that physician and their partners. And so I also mentioned the Council on Ethical and Judicial Affairs report. And so let me also paste that. And again, you guys can copy this and look at it on your own, but just to put the links in there. So CJA, our Council on Ethical and Judicial Affairs, was referenced. There was a slide in the last presentation about a member of CJA and their comments. But the role of CJA is to maintain and update the AMA's Code of Medical Ethics. And it's a very sort of independent entity within the American Medical Association. And so one example of that is that when CJA makes a recommendation, let's say CJA came to us with a report about this is how we should approach private equity. And let's say that the House of Delegates wasn't aligned with CJA on this and voted to say, you know what, this is not right. You should change this, this, or that. That's not allowed, right? So this ethical opinion is not something that can be amended by these 600 some physicians. Either we accept it as the advice of CJA on the ethical practice of medicine, or we send it back and CJA can send it back the exact same way, or they can adjust it based on the input that they hear from us, but it can't be changed. So the ethical opinion of CJA is not something that these 600 physicians create. It's something that this group of physicians with a background in bioethics create. So a very professional group, and it's not amenable to tweaking. And it's directed by our House of Delegates to look into the ethics. And so we had a report that was created, and you see that in the link, about the ethics of private equity ownership. And this was directed by the AMA. The AMA basically said that we wanted a study to clarify the ethical challenges and considerations regarding professionalism in the physician community as it relates to private equity ownership. And so that's what you see in that link that I sent you. And I'll just kind of highlight what the language that they said was in this report. That physicians have a fundamental ethical obligation to put the welfare of patients ahead of other considerations, including personal financial interest. And this obligation requires that before entering into contracts to deliver healthcare, physicians consider carefully the proposed contract to assure themselves that its terms and conditions do not obviously compromise their ability to fulfill their fiduciary obligations to patients, right? So basically in this line, it basically says, whatever it is you do to finance your practice, it should not compromise your ability to take care of your patients. This is the ethical opinion of CJA. So CJA didn't come out and say that this is a bad idea, but they're putting parameters on it to basically say, if you engage in getting capital to finance your practice, which people do with hospitals, people do with private equity, that it can't interfere or compromise the ability to fulfill their obligation to their patients. And so they're saying that, carefully review the proposed contract terms, minimize these conflicts of interest, do not compromise the physician's ability to provide high quality care. And then, when physicians enter into these arrangements with partners who may later sell that practice, that physicians should seek explicit commitments that subsequent partners will also sustain this fidelity to patients and respect that professional ethical obligation. So these are the parameters that our own ethical and judicial affairs basically put on this, not assuming that it's all bad, but saying that if these things are within that contract, then it's something that could be reasonable to pursue. And just to highlight some of the recent research that's been done. So there's a growing body of academic literature on private equity influences on physician practice. There was a recent quantitative study that was published in Health Affairs that basically compares clinician workforce between private equity acquired practices and practices that remain independent. So just some of the findings from that. So not surprisingly, it revealed that there's a significant increase in the number of advanced practice providers, so non-physicians, in that PE acquired practice relative to non-PE acquired practice. Same thing that we just saw in the previous presentation. There was no significant changes in the number of physicians in this group that they looked at, but there was evidence to suggest that there was a higher physician turnover rate in that PE acquired environment relative to independent practices. But that's not unexpected when you see people that are entering this in the tail end of their career. We have an ongoing dialogue with Professor Brutch at the University of Chicago, who was the lead author in that study, to basically continue to look at this data and to inform physicians in the future about, again, continuing relationships with PE. So in 2023, our physician satisfaction and practice sustainability subsection of the AMA or work within the AMA conducted a series of interviews with physicians who sort of went into these practice transitions, both going into private equity relationships. There were 10 of those who transitioned from private practice to that corporate employment, another 10 that went from corporate environments to private practice, another 10 that went from clinical practice to early retirement or non-clinical work, and then 5 who sort of looked into that transition but stayed put. So overall, sort of this 35 physician cohort. And the findings there regarding drivers of practice transitions are largely sort of intuitive, with the most pertinent being that a mismatch of values and expectations that causes discontent is the main motivation, right? So if you're in an employed situation and you don't like what's happening, that's a motivation to go into private practice. When you're in private practice and you're tired of running the business and decreasing reimbursements and having to have 1.4 FTEs just working on prior authorization, you seek the stability of that employed setting. So these are sort of the motivations that move people back and forth. Dr. Konda also referenced a report that's our corporate practice and medicine brief that I'm linking is in the chat right now. So basically this, is ideally what would guide this. But as was already mentioned, this has been weakened over time, right? This corporate practice of medicine and the management of that. So some states, the laws don't even exist anymore about how to govern the corporate practice of medicine. Other ones allow broad exemptions. Like, for example, hospital ownership is something that's allowed now as it relates to the corporate practice of medicine. And there's a lot of workarounds in this as it relates to private equity. So private equity will create a physician management company that then becomes the ownership entity, or a management service organization that then becomes the ownership entity. So this corporate practice of medicine needs to evolve. The guidance around this, I would agree, needs to evolve based on the current environment. So I'll summarize here that, the AMA policy on private equity is based on the experience of our House of Delegates, right, which represent every specialty, every state. Our policy is voted on by these 600 some physicians that come from all of these corners and types of practice. We're very aware of the mixed reception that private equity gets in the physician community, especially as it relates to those that are early career versus tail end of career. And we're approaching this influence of these various groups with resources to help physicians to assess these opportunities and know, what to look for and what to avoid. And we're closely watching what impact these relationships will have on patient care and physicians' practices. But we're not coming to that conclusion about whether they're good and bad, because we think that there are some relationships that could be useful to physicians in a way that maintains their ability to take care of patients the way they see fit, and some that are bad situations. And finding the characteristics of group 1 versus group 2, the good versus the bad, will help inform physicians in these decisions earlier. So not assuming that they're all bad. On a side note, surprise medical billing was mentioned, sort of, and the influence of private equity on that. And I will share with you that hearing testimony about private equity and their influence on surprise billing, we are in no way defending the overutilization and sort of the antics that are already highlighted in some of the other presentations today. So I had the privilege of being able to go and give testimony in Washington, D.C. early in the surprise billing hearings in the Energy and Commerce Committee in the House. And basically, my opening line was that we are not defending the abuse that happens as it relates to surprise billing, where a private equity firm acquires all of a given specialty. So if a private equity firm came to Flint, Michigan, and bought all of the otolaryngologists or purchased their practices, and now we work with that entity, and all of a sudden, the $100 that I charge to cauterize a nosebleed goes up to $400 overnight, that's not at all what we're defending, right? But what we are defending is that if there's an insurance company in town that just absolutely sucks, right, and has all sorts of paperwork required just to be able to do that cauterization, and I decide not to participate with that insurance company, I shouldn't have to take their payment of $100. If I don't participate and my usual fee is $150, that they should pay me $150, right? So that's what we're defending with our No Surprises Act, not the gouging that sometimes happens with private equity. Is there a role for more leverage in contracting with insurance companies without gouging? Sure, absolutely, right? Shouldn't I have leverage to be able to, charge customary and reasonable fees without gouging? Absolutely. And so that's what we're defending with the No Surprises Act. We also heard a lot of criticism about non-physicians getting into healthcare and managing the care of patients when private equity takes over. Physicians retire, get bought out, and get replaced with non-physicians. That is not at all what we're defending. The AMA has worked for decades in a scope of practice partnership that we've invested millions of dollars in to promote physician-led healthcare teams. And so I don't want you to think that this consequence of private equity replacing physicians with non-physicians is something that the AMA is okay with. Absolutely not. And so is it possible that getting an investment from private equity in a hands-off manner could actually see the goals of physicians that enter these relationships become realized? Sure, absolutely. But that's what we're in, is that data gathering mode, not assuming that every relationship with private equity is bad. So we are very tuned in. We are staying tuned for characteristics of where this influence of private equity can be helpful and where it should be avoided, and using that to inform the million physicians that are in this country with our work product. So I'll stop there and happy to take a look at the chat now. I know it's been busy, and answer any questions that come up.
Thank you, Dr. Mukkamala. Are you do you have a hard stop at 5 p.m. or in 20 minutes?
I can go to about 5:15 actually, Nick.